Ladies and gentlemen, welcome to Chatham House, the Royal Institute of International Affairs, and we're absolutely delighted to be hosting you today for a very special event for us that we're co-hosting with the Access to Medicine Foundation. And we specialise here at Chatham House in our Centre for Universal Health on issues related to the political economy of health and health reforms. And I don't think any issue has perhaps been more politically important throughout the entire pandemic than access to medicines and vaccines. We saw that at the height of the pandemic, the UN Secretary General say at one point, the science is succeeding, but the solidarity is failing, and major concerns about a lack of access to medicines, particularly in developing countries. Now, as part of an initiative to improve this, the Access to Medicine Foundation do this wonderful index that they produce every 2 years to show how progress is being made, or perhaps not being made sometimes, in improving access to medicine, and actually looking at the different performance of pharma companies in achieving improved access to medicines. And we're absolutely delighted to be having this event to help present the new report that you'll hear about in a moment. But then we're going to have a discussion amongst this eminent panel that we have with us to really sort of reflect on the report, this year's report, but also the broader topic of how do we improve access to medicines coming out of the COVID-19 pandemic. So I'll perhaps introduce the panel now, and then we'll have the presentations, and then we'll go to the panel discussion. And we have actually 4 panelists. You can't, perhaps you can't see on the screen that we have. I think, are you in South Africa today? Are you in South Africa today, Lwazi?
I am. I'm broadcasting from Johannesburg.
Excellent. So Lwazi Manzi, Dr. Lwazi Manzi is the head of the Secretariat of the African Union COVID Commission, and has been very active in the NHI reforms in South Africa, where I've worked with you before, Lwazi. So it's fantastic to see you again. We have Gwen Hines, who is the Chief Executive Officer of Save the Children UK, who has been doing a lot of work in improving access to medicines. We have Her Excellency Dr. Zainab Shinkafi Bugudu, who is Chief Executive of Medicaid and founder of the Medicaid Cancer Foundation, and is also the First Lady of Kebbi State in Nigeria. And finally, we have Dr. Ebere Okereke, who is the Senior Technical Advisor to the Tony Blair Institute of Global Change, and is also co-leading the Africa CDC-led partnerships for African vaccine manufacturing. So an absolutely fantastic panel. I'm sure we've got lots to say on the topic of access to medicines. But if I can hand straight over to Jay Iyer, who is the CEO of the Access to Medicine Foundation, who's going to introduce the report for this year.
Now, whether you're joining us today online or in person, we're really happy that you're here and able to spend a few hours discussing this topic. And we appreciate the opportunity that hybrid events give us to make sure that participants, whether online or in person, whether an audience or our esteemed panelists, are able to join us. And we, of course, appreciate also the current landscape of how difficult it is to travel and attend a lot of events, considering flooding, train delays, visa problems, and also the fact that you're away from your families and your current commitments. So thank you for being here this morning. The Access to Medicine Foundation, we're an independent organization based in the Netherlands. We're a small team. And for about 15 years, we've been evaluating how the pharmaceutical industry and their partners have been addressing access to care for people living in low and middle income countries. In a few minutes, my colleague James will walk us through this year's findings. I think the main thing here is we've seen that in the last decade, there's been significant scientific progress that has really transformed the lives of people around the world. Vaccines for children, the improvements we've made in HIV care, and still able to make access to oncology medicines. You know, the fact that these scientific breakthroughs are available is actually a great gift and a miracle. But of course, we all recognize, which COVID has laid bare to us, the gross inequities that are there, that people all around the world still do not have access to these essential health products. And health systems are fragile. So every hit that they take has an immediate effect on patients' lives. and people's lives, caregivers also. So today, I wanted to tell you a little bit about, our work. We're a foundation that basically has been tracking the pharmaceutical industry's activities. Every single day, my team evaluates companies' activities. We do this for the big pharmaceutical companies, and today's report will be about the largest pharmaceutical companies in the world, and research-based pharmaceutical companies. But we also have started programs on generic medicine manufacturers, and we'll be looking at diagnostics, vaccines, and importantly, also the medical gas companies, medical oxygen, which I think many of you have started to realize that it's an extremely rare commodity in many parts of the world. So, and we use our research to stir dialogue. I'm hoping that the dialogue today will also be inspirational. In order for people to realize that at the end, it's the political will, it's the will of us in the room and those that are not in the room online, and our ability to sort of change the landscape that makes a difference between life and death for patients. So I think with the worst of COVID-19 behind us, at least some of the peaks behind us, I believe that we're in a turning point for global health. And if we've learned anything, it's that the work is not done unless we put our efforts here. So I hope that the latest Access to Medicine Index that has been recently launched on Tuesday will be a source of inspiration. It's a pretty big report, but James will do his best to sort of walk us through sort of the main highlights of it. And our esteemed panelists, thank you again for your time here. We'll be able to debate and discuss, what are the top priorities that all of us need to focus on in order to solve this problem of access to healthcare. Thank you again. James, floor is yours.
Welcome, everyone. Thank you for being here today. As Jay mentioned, I'd like to run you through the recent Access to Medicine Index report. We do just have a short 10 minutes and a full report of 250 plus pages. So we will only scratch the surface, but I do encourage you to check out the Foundation's website where you can access the full report, including the 20 company report cards. So with that, I do just want to spend a few seconds giving you a sense of the scope of the Access to Medicine Index, what specifically it is we measure. So in scope of the index, 20 innovator pharmaceutical companies, and we evaluate how well they're providing access to their products in 108 low and middle income countries. Our disease scope is 83 diseases and conditions. Won't go into too much detail, more detail now, but we do cover much more than just medicines, also looking at vaccines, platform technologies, and diagnostics as well. We use 31 indicators of company performance at the index, spread across 3 technical areas and 14 priority topics. So we really capture the full picture in terms of a product's life cycle, going from the governance structures and incentives and access-related incentives, all the way to how well companies are planning during the research and development phase, and ultimately providing access to products once they have reached the market. Now I'd like to give you a brief overview of the report, again published on Tuesday. This report, similar to previous reports, features a series of key findings. I'll overview those for you today. We have 8 chapters spread across the 3 technical areas that I just showed you, and 20 report cards that provide a detailed picture of company performance with respect to access to medicine. We also have identified a series of 19 best practices where we call out either a single company or a subset of companies for excelling in a particular regard. And finally, this index contains 3 exciting special reports, which I'll again overview for you now, encouraging you to please check them out in full. So this year we will feature first a report on COVID-19 and pandemic preparedness more generally, looking at what companies in scope have in their pipelines, how they've provided access to the products, the approved products in their portfolios. We will also feature a sexual and reproductive health and rights special report. Again, here we look to what companies are doing with respect to research and development into products with implications for women and girls, as well as how they're providing access to their approved products. And finally, our report features a longitudinal analysis where we have attempted to connect the dots with previous reports and highlight long-term trends that we've been observing since the index was first published in 2008. So all very exciting. Please do check those out in the full report. I want to spend the bulk of the time overviewing three of the key findings that were pulled from the index as a whole. The first key finding relates to research and development in the context of emerging infectious diseases, finding still that issues persist in that area. What do I mean by that? Of the 20 companies in scope of the index, only 5 are engaging in R&D for emerging infectious diseases within our scope. This is a real opportunity, I think, for companies to seek out strategic partnerships in order to prioritize this important research. Despite calls from the WHO and many global health organizations, the index found that the number of projects targeting emerging infectious diseases remains relatively consistent with the numbers that we observed pre-pandemic. So much room for progress there. The second key finding of the index is a more positive one, looking at recent momentum in the context of voluntary licensing and the promotion of generic manufacturing. Specifically, we found that more companies during the COVID-19 pandemic have expressed a willingness to engage in voluntary licensing, generally in the context of COVID medicines. However, an exciting development just a few weeks old was the announcement by Novartis for the first non-exclusive voluntary license for a non-communicable disease product. So while it remains to be seen whether this truly does represent a watershed moment, it is encouraging to see that more companies are willing to engage in this area, but still a call to expand these licenses to more products in a broader geographic scope, and ideally earlier on in the life cycle of a product. Our third key finding, again, largely a positive one, finding that we have seen progress in terms of companies planning for access in the research and development phase, but also implementing strategies after product launch. So what we have seen is that this cycle, more products are covered by more comprehensive access strategies. However, the picture is not a completely rosy one. If you look at this plot here, you can see, although dramatic progress in upper middle income countries and lower middle income countries, with jumps, for example, from 50 to 80% of products covered in upper middle income countries, we still see that progress in low income countries generally lags behind, with less comprehensive strategies and less geographic coverage overall. Unfortunately, this also extends to the research and development access planning phase as well, where we do see vast improvement, but again, limited geographic scope of plans, limited comprehensiveness. And finally, I will end so that we have plenty of time for the esteemed panel with maybe the moment that many of you have been waiting for, the overall rankings from the 2022 Access to Medicine Index. What we find here, GSK retaining the #1 position in our rankings, excelling with respect to the size of its priority pipeline, as well as its efforts to plan for access, not only in the research and development phase, but implementing access strategies for its products across country income classifications. In the #2 position, Johnson & Johnson, rising slightly from #3 in the previous index, followed by AstraZeneca, which joined the top 3 for the first time, leading the 20 companies in scope with respect to IP sharing with third-party researchers. A few other things to note, Merck KGaA joining the top 5 in this cycle, again propelled by increases in its efforts with respect to access planning and implementing access strategies post-product launch. And finally, I want to note, again, Bayer joining the top 10 for the first time through increased efforts with respect to things such as planning for access during research and development for its products. So again, I know I only had a very few short minutes with you today to cover a very long report. So I would encourage you to please check that out. Please, you will find on the website as well detailed report cards for each of these 20 companies, which will walk you through the rationale for the ranking, including how they perform in specific areas such as governance of access, research and development, and product delivery. So please do so. And thank you again for the opportunity to provide this overview.
Many thanks, James. Admirably concise. That was absolutely perfect. And I think what you're showing there is what we'd sort of say a mixed scorecard, a mixed report card. Some improvements, but obviously concerns about lack of investment in R&D in emerging diseases, and something that we're familiar with in the whole debate about AMR as well, the lack of investment in new antibiotics. I'm sure this is something that we're going to be discussing. So I'll turn over to the panelists in a second, but there are a couple of bits of housekeeping that I forgot to mention. And I hate to disappoint people who have come here to experience the famous Chatham House rule, because we are not following the Chatham House rule today. Because obviously we're broadcasting live, so it's hardly a case that we can keep it secret, can we? And I think we have a pretty big online audience, by the looks of it. So quite the opposite. We really would like you to spread the news as much as possible. Feel free to tweet, take little videos, do what you like really to help disseminate the report and share your experiences with us today. And I should also mention that if you hadn't noticed, that the toilets are sort of out to the left, and they're on the ground floor just down here. So sorry, Emma, have you got to? Sorry. Oh yes, good point. Thank you very much, Emma. You just reminded me. We do want this to be extremely interactive, and so I'm very keen that we take as many questions from the audience as possible. I know you often come to events like this, and there's like 5 minutes for questions at the end, and you leave frustrated. I will promise you that will not happen today. We've got a good hour yet, more in fact. So what we're really hoping to have is a good discussion on these vitally important topics. So I'm only going to really sort of pose sort of one major question to the panelists to get us going, but be very much looking to the audience here to ask questions, and likewise online to our online audience, if you can put your questions in the Q&A function, and they'll pop up on my screen here. And I think there's the facility as well, if I'm not mistaken, that you can upvote questions that you particularly like. This is a very efficient way for the chair to see the most popular questions. So if you see a question that's been asked and you think that's a good one, please give it the thumbs up, and then it should rise to the top of the list. And top tip for question ask: if you want your question to get to the top of the list, get your question in quick, because I've done this before, and they get to the top nice and quickly. So I'm going to go straight to the panel, and I'm going to be bringing in Alwazi first from South Africa. Hopefully you've had the time to reflect on the report, but you'd really like to ask you in sort of more broad terms, what do you think should be the priorities when looking at access to medicine and vaccines and commodities coming out of the COVID-19 pandemic? So Alwazi, over to you for the South Africa perspective.
Well, thank you so much, Rob, for having me here. It's really a pleasure to be here amongst friends, and greetings to my fellow panelists. And thank you so much to Jay and her team for this report. I did have the opportunity to engage Jay and her team, and had a look at the report. So let me begin by saying that, I'm coming in from South Africa, as you said, and therefore I come from the AU perspective, and you'll be getting a perspective of that. And as I go along, I'm going to deal with some of these key findings, which are absolutely critical. So the AU articulates its pursuit of local manufacturing for Africa in the new public health order, and has gone further to define targets of manufacturing 60% of Africa's required vaccines by 2040, and calling on large procurers like Gavi to purchase 30% of vaccines that are destined for Africa from African manufacturers. So the first step, as you said, Rob, is and Jay as well, is bold political will and clear targets. And secondly, we must never forget the debacles that led to inequity in the distribution of COVID medical countermeasures, especially vaccines. We're talking about hoarding by rich nations, export bans, contaminations at drug substance facilities. And this all exposed the dangers of manufacturing concentration, resulting in large blocks of the population untreated, and therefore waves and waves that were triggered by new variants. Now, that was an unacceptable outcome, given the meteoric development of countermeasures, as you have also said. Yet COVID-19 was still fresh in our minds, but we saw these same issues with the response to monkeypox, where smallpox vaccine stockpiles were reserved for certain regions. HPV vaccines are still being given to older boys when we've really lost during the COVID-19 pandemic and only vaccinated 13% of young girls. And we continue to see inequities persist for countermeasures for non-communicable diseases, especially cancer therapeutics. So it seems humanity has a perseverance problem. There's a psychological term called perseverance. We just can't seem to operationalize the principle of learning from the past and collaborating around the redistribution of medical countermeasures. So clearly what it will take is for us to pursue an unapologetic geodiversity agenda for pharmaceutical manufacturing and get behind the medical countermeasures platform that has been proposed as the Act A transitions. Now, for this to truly work and result in unencumbered access to medicines for all people, there's some key elements that need serious attention. First being that we need well-coordinated R&D and tech transfer to low and middle income countries, and this must be prioritized. And this must be led by governments. And even if governments in low and middle income countries cannot make the biggest investments, they should still take the lead. And this should be accompanied by indisputable regulatory institutions in all regions for all products across the world. Global regulation must be harmonized, so there's no excuses that people don't want to buy certain products because they're not sure about the regulation mechanisms, and also to ensure that we eliminate unsafe medicines. Secondly, the work of manufacturing countermeasures for infectious diseases, particularly vaccines, is in fact a business that seeks to eliminate its own market. And so it's not surprising that expensive R&D in this area continues to dwindle, and it's not surprising that we've got this key finding of only 5 companies that are continuing to engage in R&D for communicable diseases. And so the only entity that really stands to benefit on economic scale from investing in the elimination of infectious diseases is in fact the government. So maybe we should actually accept that governments must take ownership of manufacturing for infectious diseases while the private sector provides services and therefore minimizes their risk whilst being useful to the broader geodiversity agenda. As an example, this is what Morocco is doing, and this type of public-private partnership model is what members of the COVID-19 Commission are advocating for. You'll hear a lot more about this, and we discussed this when we were actually at the World Health Summit in Berlin. So what we're saying here is that government leads R&D, investment, government owns IP, government licenses the IP to private industry and the manufacturers and private manufacturers. And what this also implies or probably means is that if governments own the IP, they can politically commit to share it with each other and promote tech transfer in the interest of global socioeconomic security and peace. And in fact, actually, at this point, I should say that the reality is that indeed governments do actually put in the significant investment into R&D for infectious diseases, like in the case of Moderna. And therefore, it is in fact taxpayers that fund R&D. But somehow we've gotten into a situation where the risk has been socialized and governments have not retained the IP and the profits are privatized. And we really, really need to challenge this and turn it around and rather create a win-win ecosystem in public-private partnership for infectious diseases. More broadly, for both communicable and non-communicable diseases, and it's great to see that there has in fact been a licensing or at least a signal of licensing for non-communicable diseases, and let's hope that this is something that's going to grow. We should draw inspiration from what Act A at a global level, and examples like the Solidarity Fund and the national level achieved in terms of pooling resources and coordinating around 5 aspects. And this now assumes that we cannot, or private companies are not incentivized really to transfer tech because, it's non-communicable diseases. They want to be able to enjoy the exports going forward. That's okay. But we can come together and we can coordinate around access by ensuring, one, that we identify where all the countermeasures are. This is what Act 10 Solidarity Fund did. 2, quantifying the cost of acquisition, distribution, administering, including the cost of health workforce training, deployments, and other last mile costs. 3, using economies of scale to de-risk. 4, coordinating the logistics around one plan for all people. And 5, adhering to principles of universal health coverage, that is access where people are at zero cost to the people. We have shown that this is possible. With proper collaboration and coordination. We should learn these lessons and actually proceed with this kind of collaborative spirit. Now, finally, what I'd like to say to industry is that, like governments, industry should also adopt progressive political commitments to fair and equitable distribution of countermeasures. Now, I see in the report that, in planning for access during R&D, that is starting to happen, but admittedly in the report, there's still a lot of work to be done. And this is what we'd like to encourage, is that industry should also take on the responsibilities of government in making these political commitments. Industry was too inconspicuous when it came to this kind of work during COVID. For example, it took far too long to decide to swap delivery schedules. And this was also actually led by government, but industry could have actually taken a stance on this right from the beginning, based on principles of equity and an appreciation for the sanctity of life. Industry should move away from the dogma of selling to the highest bidder, and industry can disrupt the status quo by working together with governments, trade organizations to configure a new order where there's coordination between manufacturers, countries, regions, and pooling instruments to prioritize distribution based on need, not on wealth. In this regard, it's very good that we have the Regionalized Vaccine Manufacturing Collaborative, which has emanated from the World Economic Forum, and let's ensure that this particular collaborative does these kinds of things and makes these kinds of political commitments. I'll wrap it there for now. Thanks very much, Rob.
Yeah, thank you very much indeed, Wazi, and really excellent that you've given us so many concrete proposals there, and interesting to see you emphasising potentially a greater role for the state in R&D for infectious diseases. And we've heard sort of similar noises from the AMR community. One thinks of Lord Jim O'Neill, the former Treasury Minister here in the UK, and former President of Chatham House, saying that the state should get involved in trying to sort of make the industry invest in infectious diseases. So that's extremely helpful. Thank you very much indeed. I'm sure we'll have questions for you in a moment. Glad to see questions coming in. Some have upvoted already, so keep the questions pouring in, please. And I'll turn over to Gwen, please, from the Save the Children perspective.
Thanks very much. And it's fantastic to be here, to everybody in the room and online. It's nice to have both, right? So you actually have that feeling in the room as well as the people out there in the world. And like Wazi, I really want to pick up the issue of equity. And I think that's so important in our discussions today. And access to medicine is something we've seen during COVID, just how important those access issues are. So on the one hand, this should be something everybody is now firmly focused on. But we failed. There's still countries where less than 10% of people have got the COVID vaccine. And yet in the UK, I'm now in the privileged position of saying, okay, I've had COVID a couple of times. I've had 3 jabs. I feel pretty comfortable going about my day-to-day life. And I think that really illustrates the challenge for all of us. And you have an amazing innovation in those vaccinations, in people pulling together. You have people for the first time realizing medical oxygen, as Jay said, is fundamental to healthcare. We work on pneumonia quite a lot at Save the Children. And I remember a couple of years ago, people saying, why do you keep going on about medical oxygen? Surely it's there. If I turn up to a hospital in the UK, I assume it's there. I can tell you when my son had pneumonia in Malawi, it was not there. We nearly lost him, but we didn't, thankfully. And yet we saw during COVID, and fantastic organizations like Every Breath Counts was showing country by country where the next crisis was going to hit. So we knew there was going to be a problem. We knew there was going to be a problem in India, Indonesia, months ahead, and yet trying to pull people together. But the good thing is there's been so much innovation thinking about that, new ways of actually getting that, new ways of doing it. So that could be a fantastic benefit of a horrible crisis. So I want to focus on some of the positives, not just the bad. Our role of Save the Children, access to medicine is vital. We do 3 things to save the children, grounded in child rights. All children should survive, so they don't die of preventable causes under 5. They learn, so they get a fantastic education, and they're protected from violence. So access to medicines is really fundamental, particularly to that first, but also to others. I was in Uganda a couple of weeks ago, and Uganda struggled because schools were closed for 2 years because the government was worried about COVID. Because of the very, very fast growing population, that means 9 million children missed out on education. And so we're now all struggling with that long-term impact. When I was there, Ebola was kicking off. Again, it's the wrong Ebola. There isn't a vaccine for it. It's just being tried at the moment. But you risk having to shut down an entire country again. But there is really good practice, and I want to focus on that. So 4 principles I think are very important to today's discussion, and I know they're familiar to all of you, but I think they really bear repeating. Everything should be available, affordable, accessible, and also acceptable. And that last one's really, really important because, again, we know that community acceptance is incredibly important to make vaccines, to make medical products have the greatest impact they can. And a very brief case study in 1 minute for you, something we work very closely with GlaxoSmithKline, GSK, it's fantastic to have some of them here today. A case study for you of where this can really, really work. Kenya, Bungoma County. Lots of children die in their first few days, newborn sepsis. As part of our partnership with GSK, we worked on a product called chlorhexidine. GSK did the innovation, stems from mouthwash. It's an innovation that actually can save newborn lives if you actually disinfect the umbilical cord. 15% of kids die in that newborn stage, but actually disinfection can help. You talked about political economy. So making sure that product was piloted, tested, rolled out, and then the political economy of getting it on the essential medical list in the country. Community acceptance. When I took colleagues from GSK and we sat in a village in Bungoma, and people explained that in the past they used to use lizard poo because that's what they thought was the right thing to do. Now, we don't judge what people do or don't do, but that was the reality. But another one as well was there was a similar product people had that looked in a similar package that disinfected your eyes when a baby was born. And so again, if you're not working on community acceptance education, people put the wrong product and that could be really dangerous. But when it works, you bring the innovation of GSK, the supply chain, our grounding in the community, the ability to work together to say, this can save lives. And I just want to leave you with that example. There's many, many others. We're privileged to work with many big pharma companies as well as many others here. And it is that ambition that no child will die of a preventable disease, where access to medicines, these kind of innovations, working on the big picture, so the regulatory framework, the policy, the political leadership, but it's also the really grounding that in the supply chain, getting it, so those available, affordable, accessible, acceptable. That's the way you really drive change. So thank you very much.
Thank you very much indeed. That's wonderful, Quite. And I think you know, very important as well that you broaden the discussion out sort of beyond medicine and to things like oxygen as well. And I think COVID has really shown the inequities in so many products. And obviously oxygen is a key one. And we were delighted to host an event with the Access Medicine Foundation to discuss this as well, and some of the market failures in the oxygen market too. So if I could turn to Zainab now, we've been working together quite a lot this week on London Global Cancer Week, and I've heard you speak very passionately about cancer services, particularly in Nigeria, and the difficulty in sort of getting medicines to kids in Nigeria with cancer. So Zainab, what's your perspective about sort of priorities, and perhaps thinking about from the NCD angle as well?
Well, good morning again, everyone. It's a pleasure to be here, and congratulations on the launch of the Access to Medicines initiative. Like Rob said, I come from Nigeria, which is classified as a low middle income country. And non-communicable diseases is a problem in sub-Saharan Africa. Aside from the access to medicine, people with cancer have non-communicable diseases, but if I focus more on cancer, there's issues of awareness, there's issues of access due to hard to reach areas. There's also issues of costs and financing, but the treatment, cost of treatment. Education is another very important and key issue. And if we look at the landscape and what is happening right now in most sub-Saharan African countries, in context of the findings of this Access to Medicines Index, we are living examples of the fact that there's very little research going on the continent. A lot of the clinical trials that are happening, or most of the clinical trials that are happening, happen in the higher income countries. For whatever reasons, the pharmaceutical companies do not really have the required presence in sub-Saharan Africa. Sometimes you find in the North Africa, and it's very difficult to put that in context of the entire continent. For a country like Egypt, for example, which is about half the size of Nigeria, but they have a budget that is the combined budget of the entire West African region. So it's very difficult for drugs to be developed there and for companies that have presence there for us to reflect what is happening in West Africa and other parts of the continent with Egypt. So we need to have that presence, local presence, even if it's not manufacturing. At least there should be stronger local presence. I must say that it has improved, or it's gradually improving, but it can be better. It doesn't help if the Africa CEO is in another part and they don't really have that presence. With COVID, there was a lot of work that was done and a lot of partnerships, and I want to focus on the strength and the ability to achieve when we come together and do all these partnerships. I also sit on the board of the UICC, which has a very good program called the Access to Oncology Medicines Program. And that is really focused on how to bridge the gap and improve pooling together both private and public sector. It's a very good example of putting those two parts together to have a partnership that works. And we saw recently the launch or the announcement of the voluntary licensing by Novartis, which for us in Chatham and UICC is something that we celebrate. But like we've heard, we need to be able to do that much earlier. We need to do it wider. And we need to also realize for low middle income countries, low income countries, which we saw the gap that the index has shown, there are more urgent conditions. Breast cancer is in millions, and we expect this to continue to double and triple in the coming years. So what more can we do with breast cancer and childhood cancers? Breast cancer might be a bit more complicated, but with childhood cancers, there's an unacceptable gap that exists in outcomes for us in countries in sub-Saharan Africa, even with the kind of some diseases such as Burkitt's lymphoma that is predominantly found in that area. The gap in outcome is really unacceptable. A child born with Burkitt's lymphoma in the UK and other high-income countries will have a 95% cure rate. The drugs exist, but then if you're in Africa, the cure rate is still well below 25%. And I also want to highlight, today is the 17th of November. I don't see a lot of people wearing teal. I tried. It's the day for the call to action for the elimination of cervical cancer. And cervical cancer is a condition that can be eliminated. It also represents the greatest inequity that exists in cancer. There has been, all the tools have been available. There are places that you have the political will. I'm very passionate about this. We work with the First Ladies Against Cancer Initiative of Nigeria. We have good partnerships with multinationals, organizations, some of the pharma in here, GSK and Merck, WHO, to try to produce, to increase access to screening, to vaccination, and to early treatment. We're running a part of the Success United funded program in different parts of Nigeria, but we're still seeing a lack of vaccines. A couple of years ago, if I had $1 million, or even last year, not a couple of years, we blame COVID for everything. If I have $1 million in my pocket, I couldn't buy 1 vial of HPV vaccine in Nigeria because it's being concentrated in the high-income countries that are paying much more than the Gavi Alliance and the low-middle-income countries can afford to. It's still not available. It's better for out-of-pocket now, but the majority of the people cannot afford it. We've run several pilot studies, and it shows that with the right awareness, with the right education, these things are acceptable. A commonly given excuse for not providing these medicines and other innovations to the poorer countries is that it's not acceptable and the demand is not there. But with the right education, with the right putting it together in a way like with chlorhexidine, all we needed to do was change the packaging. And so people know that this is for the eye and this is for the umbilical cord. We found that with the right education, the vaccine for HPV was very much accepted. And today I still get calls from the areas that we did the pilot studies asking, when are you going to come and vaccinate the rest of our girls? They don't even know that we can do the boys. Meanwhile, we have countries that are already vaccinating boys. And this is something that's been in existence for over 15 years. So call to action, we can do better, we must do better. We've done it with conditions like COVID. Everyone came together. There needs to be more robust partnerships. Nobody can do it alone. Africa is not able to do it alone, but with the partnerships and the aid and the coalitions that are coming up, you know, I'm really very proud of the fact that Novartis has been able to do this voluntary licensing, and we hope and look forward to more and more coming for the other cancers that I've spoken about, particularly in childhood and women-related cancers, as well as the other vaccines, other conditions, products like vaccines for cervical cancer. Thank you.
Thank you very much indeed, Zainab, and a passionate call there, particularly around cervical cancer. Perhaps I've got just a little touch of TLMI UHC umbrella here, but perhaps it was designed that way to include all diseases like that. But it was really interesting actually that we had an event. I'm not sure if you were in on this one that's about UHC and cancer. It must have been about 4 or so years ago now, where we had all people from the cancer communities, you know, clinicians and health workers and manufacturers, patients as well. And we asked this question, you know, if there was one cancer that, you know, say through a UN resolution or something, we would really sort of tackle first, what would that be? And I was expecting there to be an almighty row and no one would be able to agree, but no, quite the opposite. It was cervical cancer came, everyone said we've got to deal with cervical cancer. And I was then made aware that I think Rwanda has actually got an eradication program, hasn't it? So which is fantastic. And I think Rwanda and Australia, is it, are due to be the first two? So, I mean, it does seem feasible everywhere, doesn't it? So I think that's very, and I believe the Commonwealth are having an event on cervical cancer. Well, which might even be now, actually. So we're in solidarity with our friends at the Commonwealth. Aberi, if I could finish for you, please. Thanks.
It's a tall order to try and follow these fantastic speakers who've covered all the key issues. So just first of all, a point of correction. A few months earlier this year, I stepped down from co-leading the Partnership for Africa Vaccines Manufacturing. I remain an advisor and a strong advocate for that initiative, but I'm not co-leading at the moment. Lwazi mentioned a lot of what were the challenges as we see them from the African perspective, and you've gone into details actually talking about the coalface, the front line, and the impact of the current situation on patients, on people. I want to summarize essentially because there's very little that I can add to this conversation and say the three themes that are coming out from what I'm hearing my colleagues here say is equity, partnership, and responsibility. And I'll start by saying, okay, first of all, congratulations on the little progress that has been made. But I've been in too many rooms in response to the COVID pandemic where the pharmaceutical industry has been congratulating itself. And Rob, you did say I could be controversial, so I will be. I want to say, if I was your teacher marking that report card, it'll still be very full of red. So 1 or 2, blue marks for the effort that you've made towards licensing and some of the R&D access, but there's a heck of a lot more that needs to be done. But I'm not only placing responsibility here, and I mentioned responsibility as the key asset on pharmaceutical industry. There's a responsibility on government, on the political ecosystem globally. We are funding that research. Let's make no games about it. Taxpayers, and therefore their governments, are funding the research that leads to these products that the pharmaceutical industry are making profits from. And I am not anti-profit. I am not claiming that you shouldn't make any profit, but there needs to be equity in that. And the issue in equity here is there is a failure to see humanity as one. Because if you did see humanity as one, you would not be comfortable with a situation where an innovation has been available that is saving lives, and the vast majority of the globe don't have access to it. We have a joint responsibility to change that narrative, and that's where the key of partnerships comes in. And these have got to be true trust-based partnerships with mutual responsibilities and mutual shared commitments. So we need industry to enter into these partnerships with governments, with regional institutions. And we all talk about the COVAX and COVID as if this is the first time we've had this challenge. Access to medicines, I mean, this index has been reporting for 15 years, and the problem has existed for as long as we've had innovation for healthcare. It's not new. This isn't the first pandemic either. We're still dealing with the consequences of the inequity to access to treatment for the HIV pandemic. And my concern, my fear is we ignore these things for too long, and emerging infections end up being the next neglected tropical disease. There's a lot of talk now about COVID is now endemic. So the perception in the global north of that endemicity is, oh, we just get vaccinated and we're fine. Endemic diseases in countries that don't have access to the treatments, to the vaccines that are available, are killing people. How many million people die from TB every year globally? Most of those people are in low-income countries. There are effective treatments. There are new treatment regimes that are shorter and more accessible, but are still not available to those countries. And this isn't just about new innovation. It's actually about thinking about what we already have. And again, it comes back to a shared responsibility to make it happen. Now, I'll face the responsibility of governments. Razi mentioned very clearly the fact that governments need to actually own IP of the products that they're investing in the R&D for. Own, share, whatever the mechanism is, but there needs to be, the current system is not working. It isn't working. Even when we've had IP licensing agreements, it's usually towards the end of the patent period, which is still, 10, 20 years down the line. So that's still 10, 20 years later for access to those countries that are not able to pay premium for those resources. So that is not equitable partnerships. That is not a trust-based relationship. We need to start in the innovative phase. The collaboration, the partnerships needs to start at R&D. We're talking about Rwanda being at the top, the front line for elimination of cervical cancer as a public health burden. But we're using a vaccine that actually doesn't exactly match the serotypes that are predominant in that region. And that's because there was no engagement with that region, the African continent, in the R&D that led to development of vaccines. And this isn't impossible. It isn't that hard. But governments have a responsibility to create an ecosystem, because the first response from industries, it's too hard. The markets aren't accessible. We can't do research there. So the Partnership for Africa Vaccine Manufacturing, for example, has looked at developing an ecosystem to enable manufacturing in the continent. It's looked at developing the workforce, there's a talent, the R&D architecture, looking at pool procurement, enabling access to finance, critically regulatory architecture to ensure that those excuses are no longer there. We then need the industry to say, okay, you've done your part, we will come in partnership. No matter what PAVM does to achieve the ecosystem, if industry doesn't agree to partner with them, nothing will happen. And we are not seeing enough technological transfer. We are not. If we don't see that, we'll continue to have the same status quo where come the next pandemic, and I'm usually, I call myself a pragmatic optimist, but when it comes to this, I am increasingly pessimistic because this is not the first pandemic in my own professional career, definitely not in our lifetime, where we've had these conversations. This brought it home big time because it was such a globally large pandemic, but it's not the first time. And if we don't actually take serious steps, innovative, bold steps to change the status quo, 10 years' time, we'll be talking about these same challenges again. So we need governments to do their part in setting up the ecosystem. And part of that ecosystem is creating demand. Because the other argument is, how can I be sure that there's a market out there? So we know that, say, take the African continent, we know that there is a population there. There is an under-penetration of existing vaccines and the potential, but governments have a responsibility to translate that need into demand. And they're beginning to do that. So Nigeria, for example, has actually for the first time developed a vaccination policy strategy for the country, which is actually starting to plan for the new vaccines that are available now and are coming down the pipeline. We need governments to take responsibility in partnership to start to lay the architecture there, pool procurement being a necessity. You can actually provide some assurance and guarantee complementary funding, because we recognize that coming into new markets costs a little bit more than established networks, but they are beginning to do that. So we need industry to meet government halfway. We are seeing some of those movements moving, but it's not enough. We need to recognize that there are new instruments that provide opportunity. The World Bank Pandemic Fund, which they're very grateful that they finally decided to call it something really short rather than the 50 PP, whatever it was. Pandemic funds, simple, straightforward. I don't like the name because it suggests that it only operates in the pandemic. I'd like it to be called Health Fund, so that it's actually about health equity. It's about developing the architecture in peacetime before the next pandemic, preventing the next pandemic if possible. Regional development banks have started to invest in this. The Africa Development Bank has a pandemic fund that it's creating to support industry to come into the continent to build. The African Union has its free continental trade agreement, which is to enable much more efficient movement of essential goods, and pharmaceutical products are in those groups. And finally, worth mentioning, the Africa Medicines Agency, which will have as part of its core mandate now that it's been ratified, to harmonize and increase or elevate the quality of the regulatory architecture for medicines, not just vaccines, on the continent. So in some of these low-income regions, and I speak specifically from an Africa perspective because that's the one I know the most, government is doing its part. So we need industry to stop saying it's too hard and step up. And it is going to cost you. Your profit margins might reduce, but that is okay because the goal has got to be equity. And you are healthcare providers, whether you see yourselves as businessmen or not, industry is part of the healthcare system. You have a duty to step into this space. I'll stop there.
Fantastic. Thank you very, very much indeed, Barry. And fantastic as well that you're sort of mentioning the shared responsibility, I think, between sort of governments and pharmaceutical industry, and perhaps something we'll touch on a bit later. How do we encourage governments to increase their spending? It takes two to tango on this, and someone needs to buy the medicines. And of course, we're conscious of many countries where public health spending is flatlining at about 1% of GDP, and very little seems to be spent on medicines, especially NCDs, which is a huge problem. But anyway, I'll keep true to my word. I've got millions of questions I'd like to ask. But I'm going to go straight to the audience, and I'm getting some questions online, and winning at the moment online is anonymous attendee. So I'll be asking that one in a moment. But I'm going to give first shout to the room. So we've got a fantastic mixed stakeholder group here. I think we have industry people, we have CSOs, we've got people, real experts in the field. So I'm sure we're going to get a question or two from the room. Who's going to be the first to plunge in? Right, yes, marvelous. Thanks very much. Always good idea to get a hand up first.
All right, taking the plunge. And thanks so much for this talk. It's been amazing, learned so much. Where in this picture, I would love to ask, do diagnostics sit and access to clinical lab testing, population screening, and that kind of thing? So my name is Toby, I'm co-founder of a company in this space, super interested in how we can help and get involved and deliver value. So I'd love to hear from you guys.
Great, very clear question. Diagnostics and a very hot out the blocks.
Though as you mentioned, the new public health order for Africa, which is a framework that the African Union has adopted to improving health on the continent. And amongst those priorities, there is it's not just vaccines, it's vaccines, therapeutics, and diagnostics as part of not just improving health outcomes, but pandemic emergency preparedness as well. We talk a lot about the emergency preparedness and the importance of surveillance. Surveillance needs diagnostics, it needs accessible diagnostics, it needs cost-effective diagnostics. And we've had, again, I talk a lot now about the pandemic dividend that we do need to leverage. COVID, this pandemic has actually accelerated access to rapid diagnostic tools that have been in development for a very long time. And as economies of scale have been achieved, we think that the cost should come down and the opportunity should be expanded beyond COVID for diagnostics to be much more accessible so that we know what that emergent disease is sooner rather than later. And so I think everything that we've talked about here is as relevant to therapeutics, to vaccines, and to diagnostics. And unfortunately, diagnostics don't seem to have the same profile in terms of public visibility. But quite frankly, you're not going to have you won't know which disease you want to prioritize development of vaccines or therapeutics for if you haven't got the diagnostic first. That's the first step, I'd say.
Yeah, go ahead.
And just to stress, we do work on the global issues, but I feel like part of my role today is to really ground it in some of the realities, and I completely agree. And I think diagnostics are even more important where resources are tight, where pressures are tight. You know, one of the challenges of pneumonia, which I talked about before, which is the greatest infectious disease killer of children, kills more than malaria. But in many places where you go, people see a child with a fever and they assume it's malaria. And so therefore you're wasting money treating something that isn't the problem and not dealing with an issue that is. And again, you know, I talked about my own son having had a very scary experience. I bought an oximeter on Amazon, frankly, and I've always carried it with me. Now, again, oximeters during the COVID pandemic, people suddenly realized, oh, it's quite a good way to realize whether people are struggling with oxygen. How do we get that kind of innovation everywhere? And from an equity lens, the ones designed at the moment work better on white skin than black skin. So that is an equity innovation and an equity issue that needs to be tackled. So just as an example, there's lots and lots of things, and these are very, very small practical changes to existing technology that would make a massive difference, both to people to prevent suffering, but also cost efficiency and to enable to reach more children with the same amount of resources.
Thanks. What was it? I saw you nodding away there. Do you want to sort of come in from the EU perspective?
I just want to add one more thing that takes us even more to ground, and that is the issue of home testing. It's become a great buzzword, which is wonderful because we've seen the successes of home testing with HIV, we saw it with malaria and other pathologies. And there's a lot, around home testing. You know, it's about educating, it's about getting the diagnostics outside of the clinical setting, getting them to supermarkets and other settings that are not really known to actually sell these kind of products, and therefore that comes with accreditation issues, etc. So it does actually require some level of, not high level, but some kind of technical level, political policy making, law making, etc., to be able to actually enable that. But again, industry can actually come in, step in, and do the studies, demonstrate the efficacy of home testing, and advocate and agitate then for governments and for technical personnel to be able to actually provide an enabling environment for that kind of setting. Thanks.
Excellent. Thank you very much, Nidrachi. And one more from the room, and then yes, maybe the gentleman here first. Thank you.
Yeah, hi everyone. Good morning. Great conversations all through. I'm Ubasina Chiotonye from Crown Agents. I did want to ask a particular question concerning something that was raised about development of the right policies for enabling environment. But often what's actually noticed is that those policies lie dormant. Then several years later, they are reviewed without any form of milestones or achievements to track these policies. What would be your advice or your conversation around policy framework implementation? Because I guess that's one way to draw the private sector to be bounded by those rules and regulations or those enabling environment that we're speaking about. Yeah, thanks.
Great. Who's going to do that? The policy.
I can tackle that one, Rob. If
Yeah,
that's
otherwise
okay.
he's going to.
Yeah, sure. No, he's absolutely right. You know, that is the major frustration of policymaking and lawmaking. And what I have learned in this COVID-19 championship is that you actually need to be very, very strategic. You must really gun for the one who's going to be able to move things along. Now, in my case, I tricked my way around the AU because I've got a champion who's a head of state. So we just ask him, and then there's nothing people can do when the heads of states have agreed, they must just implement, right? So that's like a nice, okay, but you may not be able to access a whole head of state. Having said that, it's often, particularly for people who sit outside of the public sector, they just go for the first person they know, and that person may be sitting very low down the road. Then you must wade your way through policy organs and this and that, and you may never actually get to that point where, you know, actually you can move the needle. So it's very, very important to do your research in the particular market that you're going into, whether it be at country or regional level, and really identify that particular person at a particular level who has the ability to move a policy from policy into law. And into adoption, you know, if there's like a major ratification process. And then that way, you know, by strategically really approaching it, you are able to cut down on the time and the pain as well. So that would be, you know, my advice to the gentleman's question, which is very, very relevant. He is very, very correct. But also at the same time, again, you know, governments must now take responsibility, use tech to really cut away at all this red taping, you know, that's really legacy kind of lawmaking that's no longer useful for us now, you know, in this tech, you know, fueled environment and people wanting things to be delivered faster. Thanks, Rob.
Great. Thank you. Yeah, please. Yeah.
So Loazi has really very clearly defined the top end of this approach. One thing I feel that is really important for long term is we actually need to activate the citizenry. The politicians work for us, the electorate. And too often in parts of the world, in most parts of the world, they do not recognize the responsibility of their governments to deliver health for them. Health is a right, not a privilege, not a choice. And therefore, if it's a right in your political system, wherever your elected government, your leaders have a duty to provide you with that right. Now, if we activate the elected citizens so that every politician running for any office should have in their manifesto something about what they're going to do for public health, and then they're held accountable. This is, everybody says, oh, it's not going to happen overnight. Of course, it's not going to happen overnight, but you've got to start somewhere. Or 20 years down the line, it still won't happen overnight. So we need to start now to educate the electorate to ask the question, what are you going to do for my health? What are you going to do? We've had a pandemic. Everybody's an epidemiologist now. We are, so yeah, everybody understands some element of what a pandemic preparedness requires. It's the question. Hold your politicians to account. If they haven't got a position, what they're going to do for pandemic preparedness, what they're going to do for access to vaccines, or access to diagnostics, then you shouldn't vote for them. It'll take time. We don't yet have the privilege of informed electorates across the globe, but we've got to start from that bottom to complement the top, to put that pressure on the politician to move away from, I've done the launch, we have a nice event with banners and everywhere and, you know, ribbons everywhere, and everybody takes pictures with the policy and then they go on. If the electorates there, every time they come to the local council, somebody says, so what's happening with implementation of that policy? We'll hold them to account. So I think that's the complementary side to addressing it from the top also.
Thank you very much. I couldn't agree more, Barry. And it's very much the focus of our centre here at Chatham House. What we're really about when we talk about the political economy of health is really trying to generate more political commitment to health from heads of government and state governors, and you know, that is around raising expectations and awareness among populations, and helping politicians understand that it's a smart thing to do politically for them, particularly coming out of a crisis. And, you know, that we've seen major shifts in governments recently in Chile and Colombia, and most likely Brazil, a lot of it related to people's, you know, sort of inept COVID responses. And of course, you know, it was the demise of Trump as well. And one can see the spectacular fall from grace of Boris Johnson really being around his COVID responses and his personal behaviour on that front. So we are seeing, you know, a lot of debate now around health and healthcare, and it's interesting that there are countries where I think health wasn't particularly, or access to healthcare wasn't particularly on the agenda. One thinks, for example, India, the world's biggest democracy, but that's a really, really hot issue now. So to be encouraged, yeah. Sorry, Mike, Emma, do you have a question, Emma? Yeah.
Is it working? Emma Ross from Chatham House. I just wanted to ask the panelists their view on the ACT Accelerator. Two related questions. One is it a keeper? Do we try and improve it and build on it and make it work better for us? Or do we ditch it and start again? And secondly, if we're keeping it, what are your thoughts about industry engagement and improvements in that level? What do we need to do to leverage that partnership through ACT-A? But I guess if you want to bin it, it's a moot question.
Very forthright. Yes, I think straight to Wazi, I think on that.
Yes,
what do you think?
I was very, very privileged to have been the Minister of the spokesperson to the Minister of Health when ACT-A started. And then, of course, when I, then moved into the COVID-19 championship, then support Ramaphosa, who was the co-chair. So I really, really got to see what ACT-A did. Now, is it a keeper? I would say elementally, yes, right? But remember that right now, we are actually negotiating at the intergovernmental negotiating body this new pandemic agreement. We just call it agreement for now. We're not sure if it's going to be a treaty. And the principle of that negotiation, one of the fundamental principles is the issue of inclusion. And one of the major criticisms that did come out in the ACT-A evaluation was that low middle income countries were not included or were included too late. And even when they were included, they didn't really know what was happening in there. Transparency and accountability for the monies that were collected and spent was an issue. And because they did not really understand, when I say they, low middle income countries didn't understand what was really going on, they started to lose interest in the ACT Accelerator. So when we negotiate this new instrument, really the issue of inclusion is going to be very, very critical, of course, and equity, et cetera, et cetera, et cetera. And the same for civil society. With the ACT-A evaluation, it did show that one of the major missed opportunities was to allow civil society to take leadership in the health systems connector pillar, which really the findings did show that it didn't perform very well. And that's probably because it was helmed probably by not the right people, not to say that they're not the right people, but they weren't the right people for health systems connecting. The people who really know about health systems connecting is CSOs, and we missed an opportunity to allow them to lead in that regard. So there are many, many lessons to be drawn from ACT-A. There were many successes, some failures, and some of those elements do need to be translocated into whatever this new instrument is. And I think that we really should be trying to just keep a very, very close eye on the instrument and ensure that, you know, it becomes what it is that we'd prefer to see it becoming. What was the second half of the question again? Or did I incorporate it in my comments? Did I deal with it in my comments?
Industry engagement.
Oh, yes. That was also, I mean, I already said this in my opening remarks about industry engagement, so I don't think I need to say more on that, but this also came out in the evaluation, you know, industries, you know, very, very low sort of engagement and them really just allowing the markets to dictate what's happening. But as I say, I think I covered that in my opening remarks. So yes, industry absolutely is part of that inclusion fundamental principle. Thanks.
Any other thoughts on, I take Gwen?
Another perspective as well to these issues, because I completely agree. And the principle of trying to come together and focus in this way, absolutely. And these things aren't going away. It's not the last pandemic. These issues of the index shows around equity and access still fundamental. My personal hobby horse is the chaos, the process, the wasted time and effort. So in a past life, I've worked in government, I've worked with multilaterals. I have more tolerance than some for these processes. But, you know, if you're in a pharma company trying to do lots of things around the world, just the idea of sitting in hours of meeting and process, which isn't really going anywhere, is very, very culturally difficult. Difficult for me. I now have the privilege. I don't have to do that too often. And I think for all of us, the global health system is a mess. I once tried to map it. You know, everybody has spent a lot of time trying to bring these things together. So the principles, the objectives, absolutely. But I think all of us need to look ourselves in the mirror and say, what is a better version of that? That is quicker, that is focused on the end result, not the process. And where did we all go right, but also go wrong? I think all of us have some shared responsibility.
Yeah. Thanks very much, Gwen. Yes, and I think there's a lot of soul searching going on, a lot of viewing going on, and let's hope it really does bring about radical change. Right, I'm just going to come to Michael Anderson, and then I'm going to go online. So hang on online. And we've got a new top of the pops. I think that Nigel Bax is going. I'm not sure we can bring Nigel on to ask his question, but otherwise I can read it out. But Michael Anderson first.
Thanks very much, Michael Anderson from MedAccess. We're a social finance company that supports access to medicines. I'm going to be naughty, Rob, and slip in two questions. One of them, I wanted to focus attention back on the Access to Medicines Foundation, because this index is a really powerful tool for helping all of us have transparency on what companies are doing. And I think over a period of time, it's had an amazing impact in that. And a lot of companies are really concerned about where they feature in the index. And it's a powerful tool. It's completely agree with Barry. It's not as far as it should go. But one of the other things we've not been able to discuss today is the Access to Medicines Foundation has done really important work on access to particular products such as insulin, but also the work of generics. And I wanted to just ask if the panel has views on, you know, many of the medicines which are actually missing in the field are those which are produced by generics. There's no intellectual property involved, but often the pricing is too high, access is low, and it's not addressed systematically. One part of that is the diversity of suppliers, but I'm slightly nervous that we get so focused on the intellectual property and the newest products that we don't pay enough attention to those things which are not on patent and which really, really are not available. And there's a political economy question, which I think Jay's organization has helped identify. I'll forego my second question in favor of others.
We might be able to come back to it, but thank you very much. And the next question about the generics and you know, the medicines that aren't on patent anymore, and you know, why are we still seeing shortages of these? Any thoughts?
That's a government issue. A lot of responsibility for that must fall on the government. Because right up till about 4 or 5 years ago, for instance, in my state, we were not producing medical gloves. All the hand gloves that you needed had to be either imported or brought in. But gradually, there are local manufacturing companies, and as you said, they don't need any licensing. They can just produce these products, and it's the conducive environment. More and more governments have policies that help to create an enabling environment, it's called, for businesses. But there's also a slight lower responsibility on the industry major players to support those in low-income countries with the technology, with building human capacity and the intelligence to be able to do these things, not just focusing on exporting it. If there's something as basic as insulin and injections, hypodermic needles, why can we not work with the low-income countries to support them as a foundation, not even the country. A lot of the pharma here, they have foundations. So why can't that be a focus? But then the government also has that responsibility to ensure that this is done. One thing that also comes up at this point is the fact that pharma always have these due diligence laws and things that the industry guidelines, what we can do, what we can't do, or this won't be allowed. A pen, even handing out pens at a forum like this can be considered inducement. So we need to get rid of those really not so important ideas so that we can focus on building industries and factories that can produce these products. With regards to government policy and also the bureaucracy and red tape that we were talking about, it's about understanding the environment and understanding where you're going to work. If you, Rob, goes to Kebbi and tries to get one of your policies to start working, you would have a very hard time. But if you partner with a local champion that understands the landscape of how things are done in that area, within the rules of law and following what you're allowed to do or not, then you're more likely to see quicker progress. But by just living in our own White House, glass houses, and thinking that we know it all with that kind of arrogance and going to operate in those kind of environments, it's not going to work.
Thank you very much indeed. Yeah, Barry.
Again, permission to be controversial.
Go for it.
The industry, whether it's within patent protected periods or generics, is a series of monopolies. That's what we have, is a collection of monopolies across the globe. And so you'll have individual providers who corner a market for a product, whether it's within patent or not. And that is why even generics are not accessible or are not affordable in certain regions of the world. I heard what insulin costs for a patient in the United States. Man, eye-watering. And what we have is not, I mean, the pharmaceutical companies are always telling us they follow the market and everything. The market is skewed. The market isn't actually real open and fair competition. They carved out individual monopolies, whether they're generics or the pharmaceutical companies that we're focusing on today. And so they control the price. So government has a duty to break up that monopoly. And expanding the manufacturing base by supporting new players to come into the field will shake that up a little bit. You can't claim that you're running a capitalist system and working in these sort of monopolies. It's not fair. You need to pick one side.
Yeah. It's astonishing insulin pricing in the US. My Twitter feed is just full of these stories, and I think people going to Canada and sort of to bring medicine in from Canada just seems breathtaking, doesn't it? Right, I promised to go online, and I will go online to Nigel Bax. I'm not sure if Nigel can come on or if that's going to be too onerous. I'll read this out, speed things up a bit. So a question for the panel about the delivery of healthcare where many poor people are needed. Many more people are needed. How might medical students and other healthcare students contribute actively to vaccination delivery and other healthcare programs? Such experiences will provide excellent experiential learning, as well as supporting countries and the region's healthcare delivery. Thank you. So Nigel asking particularly about sort of extending the health workforce and potentially engaging medical students more and presumably other healthcare workers as students. Any thoughts on that as an approach to bump up the health workforce?
Rob,
yeah, see, and we see this happening with the use of community health extension workers increasingly being given the responsibility to do more. There are countries, I believe it's Ethiopia, where highly experienced nurses have been taught to carry out cesarean sections, and this has had a big impact and in reducing the maternal mortality rates there. For medical students, it might be a bit more complicated because they have such a hectic schedule, but certainly if there's room within the curriculum to include some practical work that they can do, it makes a lot of sense. And it also would bring them closer to their communities and experience the problems that exist. I try to mentor medical students, not very successfully. I believe that we should work closer with them, both as industry, as leaders, and so on, and start to influence their thought processes in these kind of ways by making them see what's going on, so that maybe we can reduce the flight of the healthcare professionals that we see later on once they qualify. So that type of idea might be useful. So a bit of yes and no.
I know medical students were used here in the UK. Yeah, so Gwen, over to you.
Yes, firstly, I think it's a really good question, and I want to, it's an important point to pick up because, of course, products, drugs, everything are great, but ultimately it comes down to healthcare workers. And they're obviously not valued enough. I mean, in the UK, we're debating at the moment, everyone clapped for healthcare workers during COVID. And now we have a government saying, oh, well, you earn 33,000 a year, so that's enough. So, you know, putting your wage up will cause inflation, so get back in your box. I mean, in a country where living on 33,000 in London is quite hard. And around the world, as you say, there's so much that can be done. Again, there are really basic solutions that make a massive difference. Community health workers, we work with 600,000 around the world, and they are the backbone of all health services and nutrition services day to day, and also during the pandemic. And again, since we're sitting in London, in the UK, a lot of the work on dealing with COVID worked better when it was localized. And so I think this issue is incredibly important. So it's not even about medical students, but again, sustainability point, another hobby horse, so many projects are set up around the world, training community health workers, empowering them, fantastic. End of the project, money. What's the plan? And so always this assumption, oh, they'll get picked up at some point through the National Health Service system. I ran an evaluation report recently, very, very rare. So we need to build in sustainability. And there is so much that can be done there. I think medical students can definitely make a difference, but I don't want us to lose that really grounded practical support. And of course, then it's people in their own community, because of course, one of the big challenges is when you try and get people to go to really rural, remote areas. Final point, since we're being controversial, poaching around the world. Poaching for people to come to the UK, work in care homes, all sorts of other things. You know, every country is struggling. So again, we need a global perspective that says you just can't go around poaching people and offering a little bit of money because we have a problem in the UK. We need to think about global perspective.
If I can be given the opportunity to get on my other soapbox. And I agree with what you said about community health extension workers, about the role medical students can play and have played. Task shifting is not new. And in countries and regions where specialist workforce, health forces have been limited, task shifting is the norm. For us in the UK, the pandemic was, for many, the first time they saw that happen, and retired people being pulled back in, and medical students actually going on to clinics and such like. So it's great. But one thing I think we also need to recognize is gender. Remember that 70% of the health social care workforce are women, and a significant proportion of those women are unpaid. They are not in the decision-making rooms, and therefore policies are implemented that do not actually consider their perspective. And we saw that in COVID across the globe, where women were most likely to lose their paid jobs. When the lockdowns were implemented, they were expected to work from home and take on childcare and family care responsibilities. And now that everything is opening up as well, all those enabling systems like hybrid working that allow women to continue with their caring responsibilities while working are now being moved back as well. We need, in looking at how, and this isn't just about pharmaceutical system, although I also think there needs to be more women in your decision-making rooms in the industry, but we need to recognize that the women are the connection between policies we make and the people we're implementing it for. And unless we actually bring them in as part of the conversation from the beginning, not when we're looking for extra people, extra hands to deliver the system, we are working with one hand tied behind our back. So we have got to bring into this access conversation the role of women at every tier of the system, and to recognize that women should be paid. There is no caring gene that women have. They don't do it out of the goodness of their heart. They do it because society has actually left that responsibility to them. They should be recognized, they should be paid, and they should be seen as part of the health, human resources for health globally, not just in an emergency.
That's great. Oh yeah, go, yeah. Round of applause. That's fantastic.
For that, isn't it great to have an all-women panel here?
Yeah. Great.
Pick up on that and the issue of incentives and programs and work plans that we have, whether men or women, they usually, or especially with the community health workers, we do not building incentives for the workforce that are going to carry out the program. There is funding for the bulletproof car. There is funding for the cook, for the program manager and his accommodation. But the health workers at the bottom level that are going to do the actual program, it's expected that they're paid by government. But we're bringing in a new program on feeding, nutrition. And when that program ends, there might be some stipends for them. But when it ends there. For me, working in cancer, and I try to, we build the capacity of the healthcare workers at the local levels, in the local government levels. We teach them how to do the HPV screening and so on. But at the end of the day, they tell you it's not part of their job description. And so how are they going to, it's just me, one, manning this whole primary healthcare center, doing the antenatals, dealing with children with malaria and vomiting and pneumonias. And then I'm supposed to be doing pap smears or HPV samplings. It's aside from the poor number that we have, the lack of healthcare workers, there's also that issue of incentives. So there needs to be a way of really talking about it without having any, don't feel bad about it. We have to reward people if they do the work.
Fantastic. No, and really excellent points. And I'm delighted that you've all felt sort of, impassioned to get on your hobby horses and tell it how it is. And honestly, I think you've been one of the best panels we've ever had for doing that. So thank you so much for such a wonderful conversation. Unfortunately, I think we are in a hard stop at 10:30, so we're not going to be able to sort of carry on any further. But I would just really like to thank you all for being so forthright and sort of bringing up so many important issues. Particularly that last point as well about the shared responsibilities and making sure that health workers are paid. It's been an absolute honour to have this event with the Access to Medicine Foundation and their wonderful new report. I do very much encourage you all to read it, use it, and encourage companies that you're involved in to do better next year and sort of get to the top of the charts. We are seeing sort of a lot of progress being made, but as we've been identifying today, I think there's more that industry that can do, but there's also more that governments can do as well. And I think, one thing we've realized and appreciate today, these things are all highly political. And we at Chatham House will be absolutely delighted to host other events like this, bringing industry and other stakeholders together to discuss these important issues. So on behalf of James, I'm not sure if you want to do any final comments.
I had a little summary, but I think please look out for the social media that goes around it that has all these conclusions in there, and we will. I'll try to make sure that that's all covered as sort of the end reflections. But again, thank you again for taking the time today.
Brilliant.
Yeah.
Thank you very much indeed, everyone. Thank you.